Okay, good evening, everyone. I hope you can all hear me, but we might make a start now and those latecomers can join us as we go. So hello and welcome to our 7th ECHO session of the Enhancing Palliative Care series. This session will focus on depression and mental health considerations and will be presented by Professor Greg Crawford. My name is Leanne and I will be co-facilitating tonight's ECHO session with Dr Russell Shute. I'm the General Manager and Shared Care Program Manager here at GP Partners Australia. So as always, starting off our session, we'd just like to acknowledge country. So we acknowledge the Kaurna peoples who are the traditional custodians of the Adelaide region, and we pay respect and tribute to their physical and spiritual connections to land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture and to elders past and present. We would also like to acknowledge and pay respect to those Aboriginal and Torres Strait Islander people from other nations who live, work and travel on Kaurna country. So welcome everyone. As I said, tonight's didactic presentation is Depression and Mental Health Considerations, presented by Professor Greg Crawford. I thank you as always. Starting off, this project is supported by funding from SA Health through the Palliative Care 2022 Grants Project, and the project is being delivered to you by GP Partners Australia. Just some welcome and reminders as we normally do before we commence. And that's to introduce yourself in the chat. Let us know where you're joining from and your role. Your microphones are all muted, but there will be lots of time during the session for questions and discussion. So you're welcome to use the chat function to ask questions if you have any comments or you're having any technical difficulties, but also feel free to raise your hand. The didactic session, as always, will be recorded and will be emailed to you within the coming weeks. Remember not to disclose any personal health information during the session. And as always, we do hope that you enjoy our session. So how ECHO works, you're all familiar with that now, being up to session 7. We'll have our introductions, the didactic presentation, and then an interactive, we hope, case-based presentation and discussion. And as always, we'd like you to be a case presenter with all the information, and when I send out the resources to you, you can see that there's a case presentation form attached. So please fill that in and send that in to me, or you can access that via the website. So in order to get the session underway, I'll just turn now, and the panel here with us tonight will introduce themselves. So start off with you, Atif.
Hi, I'm Atif. I'll be providing the IT support tonight.
Hi everyone, I'm Naomi and I'm the ECHO coordinator.
Hello, I'm Greg Crawford and I'm in the hot seat tonight.
Hi, I'm Julian Soriano. I'm an aged care and palliative care pharmacist.
Hi, I'm Andrew Noble. I'm an extended care paramedic with SA Ambulance Service.
Hi, I'm Olivia Rygorowicz, a palliative care consultant.
Hi, I'm Russell and I'm a GP and I'm a GP lead for this project. So once again, welcome you all and thank you very much for joining us. Some of you, it's probably a long day in clinic, so we really appreciate you spending your precious time with us. But tonight should be a fantastic opportunity to listen to somebody who's got so much experience in palliative care and is going to share his experience and wisdom with us. So what I'm going to do first of all is just say, please share any questions with the chat. We'll keep an eye on it and raise issues if we feel we need to during the talk with Greg. So don't be shy, ask for them. And then after Greg's talk, we'll have a bit more of an open chat, possibly present a brief case and see what we can tease out with all the participants that are here now. So it's my pleasure to introduce Professor Greg Crawford. Many of you will know Greg, who's a palliative medicine physician who started out life after med school as a GP on Kangaroo Island, so and was there for quite a while. He has worked across Southern, you've been at Northern, is that correct, with various clinical responsibilities and loads. He's taught undergraduate and postgraduate students. He's done a lot of research, so he currently leads and participates in a wide variety of research projects, quantitative, clinical trial, and I guess he's been recognised with various awards. Most significantly, maybe last year, was made a member of the Order of Australia. So congratulations for that, Greg, for your contribution to palliative medicine and tertiary education. So we are very lucky to have Greg with us tonight. So I will hand it over to Greg. Thank you very much.
Thank you very much, Russell, and thank you very much to GP partners. And I'm very happy to be part of this ECHO project. Yes, please. I'll share screen. So, as Russell said, I started life in my medical practice as a general practitioner on Kangaroo Island for 12 years, and I tongue-in-cheek suggest my midlife crisis was retraining in palliative medicine. And I've been very fortunate to have had wonderful mentors along the way, and I have worked in the Southern, the Central, the Lyell with Huon, and now the Northern Service. And had some leadership roles within the College of Physicians and ANSPAM, the Specialist Society, so that I've had the opportunity to visit many other palliative care services, not only around Australia and New Zealand, but internationally. So tonight, the topic I've been given is depression and mental health considerations at the end of life or in palliative care. And I'm sure for all of you, it's a bit of a heart sink, really. When I first started working full-time in palliative care, dinner party conversations were sometimes a little bit uncomfortable. Well, what do you do? And you either get the response, well, you must be a very special person, or people change the subject very quickly, or they cry. But a doctoral thesis on depression, which really, is such, well, aren't they all depressed? And the fact is that not all of the people we meet are depressed, but we are going to talk a bit about some gloom and about some sad topics, but also hopefully at the end of our talk you'll have some insight into some of the things that we do know about depression and other psychological issues. But also I'm sure I'm going to raise more questions than there might be answers, but at least if you're thinking, then there are some things that you can do to make a difference. So I thought I'd talk about depression initially, then about anxiety, some of the issues around that, how you might assess people, and are there some other tricks and things that might help, what we might do to make things better, and I deliberately use the word interventions and not medications. And I think it's always important to put this within the context of the people we're caring for, their families, what we as clinicians, as a team, can contribute or be barriers to it, and some of the particular medical disciplines that might be involved. So I believe firmly that depression is an important issue. It's important to identify it because it does affect patients' physical health. It affects their quality of life and has a significant impact on mortality. And the rate of depression in the general medical unwell population is at least something in the order of 20 to 30%. Now, many of the studies you read will quote numbers from 5 to 95%, and that just tells you they've had trouble trying to diagnose the condition. And that is one of the challenges in this. But what we do know is that when somebody is depressed, it restricts us in our ability to manage our patients. They are less likely to understand what we're asking them to do and less likely to do what we might ask them to do. And it then impacts significantly on our ability to try and help them navigate the symptoms that might be happening at the end of life, causing us death. And if you're depressed, one of the symptoms is an increased desire for death. And that might be a rational consideration, but equally it can be a very difficult, sad and pervasive feeling. So in summary, I've told you that it's prevalent, it's poorly recognised, it's poorly treated. There are studies showing that most people at the end of life are started on antidepressants within 1 or 2 weeks of the end of their life. And you all know that antidepressants need much more time than that to have any significant clinical benefit. It causes increased suffering for patients, for their families and carers, to be looking after somebody and standing next to somebody who is severely depressed. It's terrible. It will make you feel depressed as well, whether you're a family member or whether you might be their GP or other treating clinician. And as I said, it is associated with poor compliance, poor attention to other medical things, feeling bad about themselves, and being labelled as difficult patients. And we know that if somebody is diagnosed with depression, it predicts their ability to cope with what's happening, it increases their mortality. And for health funders, interestingly, it increases treatment costs above and beyond the influence of the severity of the illness itself. So there's another lever you would think that the people who fund our services would want to provide us with the best psychosocial support structure so that we can assess and then help care for these people. So what are some of the barriers? Well, I think there are barriers that happen at the patient level, at the clinician level, and at healthcare system levels. It's always good to think about all of those. And particularly at the clinician level, I think there are difficulties in recognising it. Is this a depressive illness? Is it a major depressive condition? Or is this sadness? Is it a normal part of the process of anticipating the end of your life? And then how do you diagnose it? Do you have skilled other clinicians within your network of referrals who understand the issues of people at the end of life? And I think that, well, I know there are a whole group of psychiatrists and psychologists who do work with people at the end of their lives, but they're not a great resort, great pool of people. And it's a specific skill set to understand what you might be able to do when there is limited time. I think that most psychiatrists treating somebody who's depressed without a terminal illness have much more time to try one antidepressant, try another one, try different interventions, that these people are more able to participate in cognitive behavioural therapies, that they've got really robust brain function and energy to participate in this. And these are things, as I'll talk about, are quite limited within people facing into their lives and people with terminal illnesses. How do you diagnose it and how do you treat it? So I suggest to you that a diagnosis of depression, I was going to say it's not easy, but it's never easy. And it's particularly important to understand if somebody's had a pre-existing mental health issue or a pre-existing depression, because that predicts that they're more likely to have problems when they enter a diagnosis with a terminal illness. But many have a new diagnosis associated sometime within the journey, if you like, or of the illness that's happening to them. And frequently it's not just depression or anxiety, but they coexist. And does one cause the other, or if you manage one, will it help the other? And probably it does. But they interplay and can sort of exacerbate each other. And then some people are more prone to depression, we know, and some people have traits that make them more likely. And I might suggest that doctors are probably a good group to have the personality traits who might be more likely to be depressed. People who like to have control, who like to make sure everything's neat and tidy and in its place. And then besides the issues around depression and anxiety, but people with other serious, significant psychiatric illnesses are really important to identify if they're diagnosed with a potentially life-limiting illness as well. And then the challenge is to find the right psychological and psychiatric support to understand end-of-life issues. So I'm sure you all know the DSM classification for a diagnosis of depression. But good to refresh it. The two main symptoms, depressed mood or depressed affect. It's depressed mood most of the day, nearly every day. It needs to be for a 2-week period at least. And the other major symptom is anhedonia, or diminished interest or pleasure in doing things for most of the time. Because we all at times feel a bit flat, feel a bit depressed, lose the joy in everyday life. And so to make a formal diagnosis, you have to have at least one of these persisting, and then at least 4 of the others. Significant weight loss that's not related to dieting, or weight gain, a slowing down of thoughts or reduction in physical movement, fatigue or loss of energy, feelings of worthlessness, excessive or inappropriate guilt, diminished ability to think or concentrate, or being a bit indecisive, or recurrent thoughts of death, suicide, and those sorts of things. So rather 2 dominant ones that you need, and then you have 4 others. But you know as well as I do, people with cancer at the end of life, people with end organ failure are likely to have significant weight loss, but they might gain weight if they've got cardiac failure. But weight loss, don't move around as much. Fatigue is a dominant symptom. In fact, I think about 90% of people who are facing the end of their lives have fatigue. And then diminished ability to think or concentrate. And is it normal to think about death if it's actually a realistic approaching problem? So things that actually make the diagnosis much harder than you might think. I remember talking to a psychiatric friend of mine, and she said to me, well, you go into a room with a patient, you shut the door, and if you come out both feeling depressed, then the patient's depressed. Now, transference is one way of thinking about it. But really, the gold standard is a structured interview by somebody who's skilled to try and tease out all these issues and come to some sort of assessment. And understanding, I believe, is one step in helping. Now, putting a label of depression or saying you have a major depressive illness might actually be a negative. It's yet another stigmatized issue. But equally, for some, it may actually be a relief to understand why they feel like they do. Okay. And that's the skill of being a clinician caring for somebody at the end of life. And as I alluded to, what is normal? What is acceptable? When does it become a disease? And I've shown you those somatic symptoms, so-called fatigue, thoughts of depression, anticipating death, weight loss. And so there is a bit of a spectrum between normal mood fluctuation, an adjustment disorder, a major depressive illness, and then some of the other organic brain syndromes, delirium and cognitive failures may feed into this as well. And there are some diseases like Parkinson's disease, where depression can be a significant part of it. So there are barriers, and so within clinicians, an inability to diagnose it very easily, as I've elucidated, is not unreasonable. There can be a sense of futility that everybody is depressed, and I'm sure you've all cared for people at the end of life who've said that it's the best year of their life. They've restored relationships, they've done the things that they wanted to do. So everybody is not depressed. Or equally futile sort of thinking that there's nothing that we can do. And certainly in one of the first depression studies I was involved in, we wanted to ask every person referred to a specialist palliative care service if they felt depressed or had any loss of joy or pleasure in life. And there was lots of pushback. You wicked doctors, you can't ask that of these patients. You're just going to make their lives harder. You'll open Pandora's box. And then you want to give them some of these wicked and evil drugs with all these side effects. And you're not going to make life easier for people. So in fact, I believe we do need to understand. And I'll give you some of the results of some of that study as well. But there's a fear of upsetting the patient or the family. We might feel uncomfortable ourselves. We might not feel familiar with treatment options. And there are significant side effects with antidepressants. There are some challenges with the route of administration, and as I've suggested, time to clinical benefit is a significant challenge. And then the non-pharmacological interventions usually are different talking therapies. And with significant fatigue and significant cognition failures, then that equally can be much harder to engage in. So the gold standard is a structured clinical assessment by a trained mental health clinician. But there are screening instruments, and so we'll talk about some of the screening instruments. And it's important to understand that it's a tool, it's an instrument. It's not an actual diagnosis, but it may help you make the diagnosis as a GP, or then provoke you to get extra support from other mental health clinicians. And there are brief ones and longer ones, but they are only screening, not diagnostic. In 1997, Harvey Chochinov, who is still a very active psychiatrist working in palliative care in the United States, published a paper, and basically he asked 100 ambulant cancer patients, are you depressed? And then he took them off into the dark room, did the structured clinical interview, and came out with 100% sensitivity and 100% specificity. And what that means is that he was confident that of his cohort of 100 patients, those that said yes, they were depressed, and those that said no, they weren't depressed, were not depressed. And it almost became a dogma because it's clearly too good to be true, because it's not true. But equally, I think what it does tell us is that it's safe to ask that question. And then that's the beginning of a conversation, the beginning of a diagnostic process. And equally, there are many two-item questions or instruments or tools, and they are the two questions of the DSM-5, the two that you have to have one or the other. During the past month, have you often been bothered by feeling down, depressed, or hopeless? Or during the past month, have you often been bothered by little interest or pleasure in doing things? And that equally might give you more insight into what's going on. And in studies that I did from that original work where we asked every patient those two questions, we then did a full screen of diagnostic symptoms and published a short screen for symptoms, depression, that I'll show you as well. And quite a robust screen is pH9, and you can find all of these if you Google them, and I'll show you the 9 questions that are part of that questionnaire. So this is the short screening question that I developed with my colleague Julian Robinson quite some time ago. And it's really an algorithm to exclude and work out if you should follow up or not. And so the first question was about fatigue. And so if somebody is not fatigued, you can feel an almost 80% certainty that they are unlikely to have depression. So you can probably exclude them. But if they are have fatigue, and the majority will have fatigue, then if you ask the 2 questions about depressed affect and anhedonia, if they say yes to both of those, then definitely you need to follow them up. If they say no to both of those, then they equally probably sit in the group that you don't need to follow up. If they only answer yes to one of them, the question that we found the most useful was to talk to them about slowed down sense of movement and thinking, psychomotor retardation. Now, this is only a screen, but within 1 to 4 questions, you can decide whether you need to follow somebody up on. So I think it has some merit, and it's worth thinking about. This is the pH9, which is 9 questions. And if you look at this, it's anhedonia, depressed affect, sleep, fatigue, appetite, feelings of worthlessness or feeling bad about yourself, concentration, moving about, psychomotor retardation, and thoughts that you'd be better off dead, suicidal ideation. So really, they're actually all the questions of the DSM-5, and then they put a scoring system to it so that you can then put numbers to give you a sense of whether you need to do anything further. And for non-skilled clinicians, these things are really quite useful. Also, I think there is some benefit sometimes by administering a questionnaire to a patient that they don't actually have to answer the questions to you. By actually giving a clipboard or an iPad with some questions, you can learn a lot. And I certainly, one of those embarrassing moments in your own clinical practice where I thought that I really was quite a skilled clinician, and when I took a history from a patient, I thought that I had a good sense of the symptoms that are suffering, that I had good or reasonable communication skills. But then I started doing some routine questionnaires before I saw patients. And I discovered that I almost never asked questions about sexuality, sense of well-being, a whole lot of other questions, nutrition, that just I missed by giving a comprehensive question list. So I would encourage you to think about instituting a few routine questionnaires as well as using these sort of questions, these instruments, but also practicing your own skills of taking a history and listening. So how do you treat depression when you've decided that somebody has got a diagnosis of depression? Well, if there are organic symptoms, things that you might be able to clear, things that might improve cognition, then of course you do that. Are there some aggravating or causative factors? Well, there aren't a whole lot, but looking at the biochemistry, you may well be able to help that. But looking at the other psychological supports that are around, actually mustering the support from service groups, the church groups, Rotary, all those friends who've been saying, if there's anything I can do, just tell me, still puts the onus back on the sick person and their family to do that. But is there a way that you can actually help connect all those things together? So there's a social connection. As clinicians, I believe that we can provide significant dental support. And I think it's true to say that you should never forget the power of your therapeutic relationship with a patient. That we are actually, it's not just placebo, but the impact of our relationship, our sense of concern and care from a professional level is a really important part of it. And then other things, they might be able to participate in some psychotherapy, in some brief counselling that helps affirm them as persons, that helps their family understand, may help them to engage in that as well. And if people are well enough, there might be an opportunity for some groups or one-on-one support. I also think that some of the things that happen in palliative care units or more hospice type environments where there's life review, try to make sense of a purpose of what's happening, to see this terminal illness within the context of a whole life and not just as a disaster that's happening at the end, of helping people to gain some sense of control, either by helping them think about how they coped with adversity in the past and try and help them muster those resources or the people that help them, or helping them to relax in new ways so that they can develop a sense of inner calm, may be important as well. But then there are medications, and they may well be antidepressants, they may be anxiolytics as well. And there's always a whole lot of other medications. And I suggested I wasn't going to mention the cannabis word, but I wouldn't be surprised if we didn't talk about cannabis in some sense about this. So what general support? Well, it's sort of trying to provide some caring and empathy, some reassurance of continued care and interest when people are feeling bad about themselves and catastrophizing. I think the provision of information to the level that people want. So many people misunderstand what they're told about their disease. They assume how things might unfold, or they forget, or they're not quite feel confident enough to ask. And so I think it's important not to keep going over old ground, but to check whether people want to understand how things might unfold from here, what we as doctors might know or be able to reliably predict how the future might unfold. An inherently challenging conversation that you need to go at a pace that suits the person. None of us would want to be accused of having taken away somebody's hope by being a bit too double-barrel and blasting the information without checking that we're not causing harm. But providing information about the illness is really important. Exploring people's fears. What is it that they're worried about? And it may be something that you hadn't thought about. It may be about the pet dog, but certainly many people are worried about the dying process and the fear of uncontrolled symptoms and a fear of losing control or not knowing who to call or not having a viable support system. Some people are fearful of being dead, but most people are more fearful of the process. Not many people want to actually be dead, you know, if you're enjoying life, but there comes a time where the actual being dead is not so bad, but it's the getting there that's wrong. And of course, these people hopefully have social supports in the family who may equally be struggling with what's going on. Psychotherapies, well, there are some therapies for people who have some ability to engage in them, but they are not very prevalent. They're hard to find. But equally, you should think about some online opportunities, and you may find online groups, and particularly now that we're all connected, you might find that there are more opportunities in that domain. Complementary therapies for things that happen in palliative care units and can help gain control around relaxation, massage, diversion, visualization. I can remember as a young GP when a patient came to me and said, "Oh, I need counselling, doctor." My heart would sink. I think, what possibly could I say to them? But I'm sure you're all much more skilled than I was in my early general practice days. And just listening and reframing and putting things into context and giving some strategy.
I can sit down.
And as I suggested, building memories and also thinking about what life has been can be very useful. So we are prescribers, and so there are a whole lot of antidepressants, and in the past tricyclics we used for neuropathic pain and still use for neuropathic pain, and might have been escalated if somebody became depressed. I don't think you see many people on tricyclic antidepressants nowadays for depression, but certainly I think that you should pick your favourite antidepressant, the ones that you feel comfortable with. Within my practice, I would still use sertraline and cipramil quite commonly as first-line antidepressants. And mirtazapine is the other one that may well be used because it's said to improve appetite, and it certainly can help sleep as well, which might be a problem. Some of the newer ones, the SNRIs, might be a bit more activating, and there are a few agomelatine and ketamine that are still not really in mainstream practice, and I can't tell you where they fit in. I don't know myself. I think some of the challenges with antidepressants is that if you are going to start antidepressants, and I use them frequently for anxiety as well as depression, and I think that sometimes the purists might say you need a proper diagnosis before you start these interventions, but I'm not so sure. We treat pain without always understanding it, and so I think we can treat psychological symptoms without understanding it. But equally, you have to understand the risks of side effects and interactions, and none of us would want to do harm. And then if somebody is on a stable dose of antidepressant, most of them are oral. There is at least one, maybe two that are dispersible, but to change an antidepressant near the end of life is a significant decision as well. And then I've heard people with complicated plans where they gradually dose reduce, talking about trying to stop rebound and other sort of side effects. My practice is to try and keep people on their dose of antidepressant as long as I possibly can, and then have a very low threshold for using benzodiazepines a bit more liberally near the end of life. But there is no evidence, and equally we could have quite a heated discussion about that. I put ECT there just to be a bit provocative. I have referred one patient of mine to ECT, and it's a therapy that has very few side effects. It's probably less side effects than the drugs, but I think people need to be fairly well. It's a bit confronting, and you certainly would never do it with somebody who's thought might have cerebral metastases. So I don't think it's a big part of the therapeutic interventions. So I suppose it's like all medical practice. The challenge is not to make it all about us, it's about the person. And so, it isn't just a simple chemical imbalance in the brain. It's not just a few simple pills that will bring a sense of confidence, control, and normality. And it's not that we want grateful patients that make us feel good. So it is a challenging problem. I suspect I've brought up more questions than answers, but hopefully that's giving you something to think about. I thought I'd then go on and talk a little bit about anxiety, and equally anxiety and other psychological symptoms can vary from mild disquiet, a general sense of dis-ease, right up to full-blown panic. And patients don't always recognise it. I think it's probably easier for us to recognise it. But also to think about what the causes are. And it might not only be innate anxiety, but it may be a side effect of medication, maybe some of the therapies that they're on for other reasons, maybe some of the medications and substances that people are purchasing because they don't think we've got the full answer. And so they're off at the complementary therapy store, they're using illicit medical drugs as well, and they may be feeding into this as well. So careful history, sense of control and calm, think about all the possibilities, recognise it for what it is, and then think about how you might intervene. And as always, really think about the non-pharmacological as well as the pharmacological. So what are the non-pharmacological? Well, I'm sure it's really important about continuity of care, setting contracts, giving patients a sense of what they can do, providing emotional support, and mustering the other supports around them, giving information again and dealing with specific needs. And then thinking about some of the behavioural interventions that might be possible, as well as how a team might help. Now that depends where you work and what other resources you have to create the team. Therapeutic guidelines, palliative care. I'd like to give a recommendation to use therapeutic guidelines. And there are a whole suite of books, and the new palliative care guidelines are about to be released with an update in the very near future. And antidepressants are the first line long-term treatment for anxiety. But equally, judicious use of benzodiazepines can be useful. And it also depends on the context, how long somebody has to live, that you don't want to create another dependency if somebody's got months to years to live. But equally, sometimes the best treatment is an oral benzodiazepine or even sublingual clonazepam or midazolam parenterally if the end of life is getting close. Pre-existing mental health issues. Well, as I've said, a life-living illness is a serious stressor for anybody. And if you already have some pre-existing problems, then why wouldn't it turn up? But equally, it's important to see, have these people got a support system? Many people have been sent and supported by their GPs and have lost contact with psychiatrists or mental health teams. And those services may need to be reactivated. And it's worth thinking about, are there community mental health or other teams? But often it's the palliative care teams that are probably the dominant and major benefit in this setting, or an interaction between the two. But caring for somebody where you anticipate the end of life is coming is quite different to caring for a mental health patient where the expectation is an ongoing contracted care. So in summary, I've talked about the therapeutic relationship that we all should bring, of helping people to muster their own inner resources and to reframe and think about how their life has been possible before this overwhelming event. To think about some of the relaxation therapies to encourage you to make the connections within what is available within your service. And, you know, in an isolated country general practice, that might be the chaplain or a nurse who has a special interest in counselling, or it may be the complementary therapy, aroma massage therapy person, or if you're lucky to have a physio, they might be a person. Think about how you can access palliative care teams there is coverage around the whole state, but like all of us in healthcare, we're hammered at the moment, but that's what we're there for. And sometimes people might need a period of care in the inpatient palliative care unit to try and help break the cycle. So I thought it was worth just reiterating the issue around patients and families, and that they don't always agree. They don't always agree about what's happening. They might not agree about the best side of care. that caring for somebody is a significant burden and carries a significant mortality as well. And it's not uncommon for the carer to become the sick person. And I'm sure you've all had couples where the wrong person died first. And I think some of that is the burden of being a carer is really significant. And then, of course, the mental health issues for us as carers, and one of my studies with a PhD was to look at how GPs, surgeons, oncologists, palliative care physicians who were caring for somebody with a life-threatening illness, what the impact it was on them psychologically. One of the surgeons said, impact, what do you mean? But in fact, it was very interesting to see that perhaps it's our personalities that might select for different disciplines, but palliative medicine doctors talked a lot about it. They talked openly about how they felt and sought out help, which is not surprising because of the sort of work we do. Oncologists, it seemed, were more likely to either seek out a mate down the pub or maybe talk to their partner. Surgeons usually bottled it up, didn't talk to their colleagues very much. And so it's also important to think about your own personality styles, think about your own supports to work out where you get help. And I would encourage you to think about some of those objective psychological supports that sometimes you might need. And at different times in my career, I've sought out somebody to not always tell me what I wanted to hear, but to listen to me and then maybe reframe what's going on and help with me some strategies. I've done a recent study with one of our palliative medicine advanced trainees about interpreters and bad news. And I think it's really important to think about the interpreter as not just being an empty vessel who just puts words into a different language, but they can be right in the middle of a really difficult situation. They may well be part of an ethnic or community. They may have some conflicts with the sort of language and words that the clinicians might want to impart, and then might have some distress themselves because of the situation they're put in. So I would always encourage you to tell the interpreters what you're planning to talk about before you do it. Ask them if you think there are any problems with that. Ask them if they know the people they're interpreting for, and afterwards, always make sure, are you okay? Was that okay? And one of the studies I did, interpreters thought that a lot of the doctors that they worked with were very bad communicators and thought they could have done a better job. And I give a shout out for the cleaners and the people who are by the bedside all the time. Nurses are by the bedside for a lot of the time, but if the cleaner or somebody who is not in the healthcare team said, oh, I don't think Mrs. Smith's very well, you should listen and say, oh, tell me what's going on. So to wrap up, really, I think this cartoon, although it talks about life being impermanent, it also says to me that it's not us and them, that, we are all on this journey, and sometimes we are on the receiving end and sometimes we're on the provision end. And so there's a need to be humble, but also a need to act to the best of our professional ability to care for people, particularly at the end of life, and particularly those who have psychological issues. And if we're all rushing off the cliff, please make sure you've got your life jacket on, because I think we want to be survivors if we can. So thank you very much.
Thanks, Greg. It's absolutely fantastic. Thorough, you explained a lot in a short period of time in a really clear way. So, so thank you very much. What I might do before I understand Donna possibly has a case to share, but before we do that, I'm just wondering whether a member of the panel has got any insights from Greg's excellent talk, or there's anybody out there in Zoom land who has a question that I can share. And don't feel scared about unmuting yourself, because I think we can take, is that right? We can, we're very happy to take any questions. And if not, I might ask a contributor.
Yeah, well, I've got maybe a nerdy medication related.
Yeah, so right, so you go first.
It could be the same question.
No.
And I bring this up because I was actually talking to a GP I worked with about it today, but pharmacogenomic testing for antidepressants. Is that something that you come across, experienced, thought about? It's kind of like a new way of thinking about it, but just listening to you talk about, obviously there's a shorter period of time where we might want this to work. And the theory is that if we can pick the right one straight away, we might get better success.
Yeah, I think it's the challenge is that, you know, we know that probably up to 70% of people will respond to an antidepressant if they have enough time and pick the right one, but it's knowing who are the right 70%. I don't have any skill and understanding about the genomics of treating depression, but I think it's a really interesting area. Equally, there's a whole lot of research about pain, not that we're talking about physical pain today, to actually pick the right person, understand their own genomics and then actually modify it. I'm sure we will see something like that as well. I don't think it will ever replace therapeutic relationship. But clearly the medicines that we have at the moment are limited in their ability to actually help.
My question is, you can tell me to shut up, because you've covered a lot of stuff. You talked about, you know, ketamine, ECT. Questions about psilocybin, and Julian's laughing, smiling. I mean, there has been a little bit, and I was listening to a podcast about this yesterday, there has been a bit in the media about this. Do you see a role for something like that in the near future? Never?
Well, you know, and the other hand grenade I threw out just as a teaser was cannabis. So I think that we would all want to have more in our toolkit to treat this problem. I think that personally, I think that, you know, most of the medication that we have access to has gone through a stringent process of assessment so that we can remove the bias from our looking and sense of what's going on. And a lot of, you know, so chemotherapies came from the bark of yew trees and, you know, a lot of heart, you know, digitalis, you know, it was wonderful and then it killed people. And now we understand how you dose digoxin. So I think there are some indicators that there may be something within the magic mushrooms of life or ketamine or but they need to be studied in a careful and considered way.
So you're an international trials collaborative. Is anything like that happening?
Well, see, I don't know of any of those. My most recent sort of international work has been around cannabis, particularly around psychological issues, around GI symptoms and around pain. And we've done some exhaustive systematic reviews of the literature. And if you look at how much research is happening about cannabis at the moment, it's exponential, it's taking off. But the challenge is to have really well-designed, properly constructed studies that will answer the questions that we need. And I'm sorry to tell you that the bottom line for all of our quite exhaustive systematic reviews for all of those aspects of cannabis is that nobody can justify the prescribing of either CBD or THC outside of some sort of process where you actually collect data, whether that's a clinical trial or some other big database. And some countries around the world actually have quite stringent database collections as well for everybody who's prescribed cannabinoid. I must say the last time I was at an international conference before COVID was in San Francisco, and my colleagues who work in that part of the world are probably a bit more open to prescribing cannabis than I am, but their challenge is once they ask for something, the person takes it down to the cannabis shop and the expert behind the counter can give them whatever they choose to give them as well. It's not like in Australia, at least, if you prescribe something under the authorised process, you actually, that patient gets what you prescribed unless they go down the pub and buy some more grass or go to one of those other places. But equally, the other thing that shocked me in San Francisco, maybe I was living in the, staying in the wrong area, but there were people stoned out of their brains, lying around on the grass, and the smell or the fog of cannabis was extraordinary. So I think that, you know, cannabis needs to be regulated. It does need to be studied. Some of the challenges is that our regulators have put the cart before the horse, so it's actually available before we have all the understandings. And to actually conduct some of those studies is getting increasingly difficult because there are so many people taking it already of various compounds. And there are so many people who want to go into studies because they believe it works anyway. So,
Yeah.
you know, but equally, I'm a pragmatist, and you know, if somebody is at the end of life, they don't have so much time to live. Why wouldn't you try something that might provide some benefit? But I think the skill is to understand that anything that has an active effect will have a side effect. So you need to think that they're not without potential harm. Certainly for cannabis, there are many interactions with many of the medications we use at end of life. And one of the interesting early markers that I saw of some activity of cannabis is that some of the studies have shown that cannabis might have an anti-cancer effect in some regard. But equally, there's some other studies that show that it actually is pro-cancerous. So what do you make of that? You can't.
Good luck looking at all that.
Yeah, and so what that tells me, I think, is that we don't really understand where it works and what it does and what the effect is that we want.
Greg, and apologies, I think my phone's just died. Can you speak briefly to some of the adverse effects? I find myself as ambulance paramedics, I don't know why, because we're wearing a uniform with epaulets, but it's not uncommon that palliative patients for whom we're going to with emergencies want to have a offline conversation about our opinion or our understanding of cannabis.
You're surprised they trust you, even though you're in a uniform.
Exactly. But yeah, I think it's a point well made that you can't have an effect without a side effect. And I'm curious.
Yes, and I think
adverse effects.
And so I think that some of the studies, particularly around nausea and vomiting, which we're not talking about today, were actually conducted before we had many of the really useful antiemetics that are available for chemotherapies in particular. And so some of the studies that are cited to show that cannabis has benefit in nausea and vomiting are a bit old, but there are lots of studies looking at that now. For depression, well, you know, I think alcohol's a great treatment too, but, you know, a little bit of alcohol can relieve anxiety. It might even help depression, but a little bit more and it makes you feel worse. And then you start crying. And I think that cannabis sometimes, the effect of dulling the acute emotions might make you feel a bit better for a while. And it might help relieve the pressure and sort of starkness of what's happening around you. But equally, I'm sure there are some indicators and some of the 500 active components that are in grown medicinal cannabis that have some benefit, and we still don't understand that very well. And then people start talking about ratios of different, you know, how much CBD, how much THC. And of course, you mustn't always forget the elephant in the room that driving and cannabis is a significant problem. And so I'm part of a large funded study looking at cannabis in managing GI side effects of some of the really toxic chemotherapies to see if we can actually improve the GI nausea, vomiting, diarrhea that's produced by chemotherapies. But one of the stipulations is that participants have to stop driving, and that's a significant challenge. You know, it's sort of part of growing up. You get long pants, you get a driver's license, and it becomes a right, it's not a responsibility. Or equally, it's another loss that our patients suffer as they head towards the end of their lives.
Watch this space, hey? It sounds like there's lots more, but I mean, that's it's a great thing to talk about because I think GPs, we get asked this question all the time, and there are more and more, telemedicine clinics cropping up, offering, to prescribe CBD to people. It's it's a bit challenging.
Relation really around the whole state, and the challenge is to make sure you know who your local ones are, build relationships. And if you don't know, there is a single number, but also dial the local major teaching hospital and ask for the palliative care physician on call, and you will find one in any major teaching hospital. And we are all friendly people, even if we're woken up and in the middle of the night. But I think, to seek advice, to seek some support, to think about what are the resources that you have within your own community, and, to use a multidisciplinary palliative care team as well, if they're able to help.
Fantastic. Thanks, Greg. That's probably a good point at which to end, I think. So thank you very much, everybody, for joining us tonight. Hope you have a good rest of the evening, and hopefully you'll join us in a month's time.
That's the 15th of March.
Thank you.
On a
'Cause
Wednesday.
I couldn't think about that off the top of my
Yeah.
head.
Thank you.
I could have done it. It's 28 days.
Yeah.
Okay, everybody. Thank you very much.
Thank you. Bye.
Bye. Good
See ya.
night.
Bye.